to you. The longest we can go is an hour and a half.
I think, yeah, no, I think it'd be hard to go an hour and a half just with some constraints I have at the other end, but we'll see if we can get through things.
Correct. An hour is perfect. 45 minutes is the minimum.
Sounds good. Well, let me know when we're ready to go and we'll get started.
You got it. We're just loading up to Facebook now. We're 1 minute from going live.
Oh, send it to my wife.
And if you allow me to begin at this moment, Dr. Armstrong, to kind of just introduce you and go over some housekeeping.
Sounds good.
So we are live now. I see some people in here. More will be trickling in. But thank you, everybody, for joining us today. Just a reminder, this is being recorded. It is a webinar. So in order to communicate with our panelists and presenters today, you have a couple of options. We do have a Q&A function. We do prefer that you ask questions through the Q&A because we can relay those at a time that is convenient for our presenter. For this presentation, Dr. Armstrong requested that you ask your questions during the presentation and we will answer them most likely pretty immediately. You can also ask your question in our chat, our webinar chat on the side here. And if you have any technical issues, have any problem with the video or the audio, please let me know through the chat. And I will fix that as soon as I can from my end, that you are able to chat with everybody on that. The last option is you can go ahead and raise your hand. On your Zoom options there, you should find a little hand up, little symbol. Go ahead and click that if you would like to be unmuted to be able to ask your question live. And with all that set up, I'll go ahead and introduce Dr. Armstrong, who is talking to us about the importance of foot care, presented by the Garfield County Libraries and Senior Matters, or CASKI. Now, I will go ahead and let you guys get started. Dr. Armstrong, the page is yours.
All right, well, thank you. Appreciate that. And thanks for the chance to come and talk to you. I have to admit, I always find these Zoom meetings a little disconcerting because I'm talking, basically the only person I can see is myself. So I do have a little bit of a canned speech, but I'd much rather, if there's something that any of the people that attending the webinar want to hear about, if there's a specific problem they want to talk about, I want them to be able to just interrupt at any point. I'd much rather address items of concern to the audience than go on lecturing about something that they don't find particularly relevant to themselves. And so with that, I'll just kind of get started just in general what I do. Let me see, page down. May take me just a second to get this going. All right, so, oh, and there is some of the slides that I'm going to show may make you feel a little squeamish. So I just wanted to let you know at any point, if I share something that is a little disturbing or even disgusting to you, I apologize. I'm so used to everything that I see here that I don't think much of it. So first of all, what is podiatry? Podiatry is just the medical specialty that deals with diagnosing and treating conditions of the foot and ankle. We go through a separate track in school than MDs. We go from our bachelor's program to a podiatry school, and then we do a residency in whether it's surgery or routine care, diabetic care, wound care, things like that. So we do a residency, and then we come into practice. We have, I think, a really interesting field. The foot is actually a very complicated structure. One thing that I enjoy about it is we get to work on multiple organ systems. So in other words, there are people who just work on nerves, wherever those nerves might be in the entire body. The neurologists work on the nerves. Well, when you're a foot doctor, you work on every organ system that affects the body. So you'll work on the bones, the tendons, ligaments, and so forth. So the musculoskeletal system, but you also work on the nervous system, work on the immune system. In other words, its response to infections and various diseases. And so you do get quite a bit. There's dermatology involved, wound care. So there's a lot of different things involved that go into being a foot doctor. A foot and ankle orthopedist is also a specialty that deals with feet. They deal primarily with the same thing that orthopedic surgeons deal with in the rest of the body, which would be structural elements, and perform quite a bit of surgery. We deal with a lot of things that may be unique to our profession, like ingrown toenails, corns and calluses, diabetic wounds, things like that. So it's comprehensive care of the foot and ankle, just a little bit different specialty. You'll notice from this slide, though, the foot is very complicated, very complex structure. Over a quarter of all the bones in the human body are in the foot. And if you've heard this before, I apologize, but I do find it interesting. 26 bones for a foot, 52 bones between the two of them, about 206 bones in the entire body. So more than a fourth of all the bones in the body are in the foot. Also, all the ligaments and joints and things that you see there, the nerves can be quite complicated also. This is interesting. Most of us will walk about 100,000 miles in our lifetime. And at some point, 3 in 4 people are going to have some kind of diagnosable problem with their feet, obviously because of the miles that we walk. So feet take a tremendous amount of stress. They're incredibly tough, resilient, and effective organs or structures, but they are prone to problems because of the demands that are placed on them. So just getting into some specifics now, I don't know, again, I want to share with you information that you find relevant to you. So if anybody has something specific they want to talk about, please speak up at any point. A lot of times we get questions about nails, and I'm assuming, since the topic was the importance of foot health, that we're going to be talking about the things that affect most of us, not some of the more specialized problems that you can have. But if there is anything I can talk about, please let me know. I'd much rather address that. So the nail, the human toenail, takes about 6 to 7, and actually a lot of the time when people's circulation is diminished, it can take 9 to 12 months to grow from the root to the tip. It actually does have a function. A lot of the time we say they don't do anything. They're just remnants of when we used to have claws or something like that. But the toenails actually do provide pressure feedback to help you know where your feet are when you are walking. So there is a function that they serve, but if you have your toenails removed, the nail bed will still provide some of that function. So people worry that their balance might be affected, that their push-off strength might be affected. That's not the case. The nail can be removed and you can kind of adapt to that new reality. One of the things that's the most common pathology that we see here in the clinic, though, are ingrown toenails. Ingrown toenails, I would assume that many of you have had at some point in your life. It's one of my favorite things to see here in the clinic because I feel like there's something we can do about them. They actually have a solution. One thing we know about ingrown toenails is there's 2 causes for them that are very clear. One is when the toenails are in periods of very rapid growth. Who grows toenails very quickly? Well, it's young people. A lot of our ingrown toenails are preteens and teenagers because their toenails are growing so quickly. The more quickly the toenail grows, the more chance it has to kind of break into the skin and cause a problem, because that's all an ingrown toenail is, a toenail that has punctured the skin and created the reaction that you see in that slide. Another group that grows toenails quickly, you can guess, would be pregnant women. But besides people who grow toenails quickly, the other group of people who get ingrown toenails the most are those who try to pick in the corners. You try to clip into the corners, peel or pick your nail back. Once you do that, you set up a very dangerous feedback loop because you start to get a little sore where you've clipped it to. So you clip it a little deeper, then it gets sore there. You clip it a little deeper. So you keep chasing back those corners. And pretty soon you have an ingrown toenail that is too far back toward the root of the nail that you can't get to it. It's too painful. So what we do is we numb them. We numb the toe at the base of the toe. Maybe you've gone through this. I don't want to bore you, but you numb the toe at the base of the toe and you actually remove not the entire nail. Can you see this cursor? But just this part of the nail over. So we try to leave most of the nail intact. You can remove the nail temporarily. You can remove it permanently. This actually is a health problem. when this occurs, because you can see how that could get infected. Down here at the base of the nail, the nail root, the matrix is very close to the bone of the toe. And so this is something that should be dealt with fairly rapidly once you start to see this ingrowing, bleeding, draining toenail. And remember, again, now this is another thing I didn't mention, but if you like to ski and you like to wear your boots really tight, that's a really common source of toenail injury also. Very tight shoe gear, or shoe gear where you're constantly banging into the tip of the boot or shoe. So what we recommend is that you keep your nails cut straight across, never clip into the corners. Try to wear shoes that fit appropriately and boots that fit appropriately, and then you should stay out of trouble. It shouldn't be too much problem for you. But if you do start to see some bleeding or draining, once you see bleeding and draining, that usually means that you're going to have a portion of that toenail removed. So any questions about that? Ingrown toenails? If not, I'll just move on. But feel free to, circle back to that if you have a question that comes up. We do have nail deformities. Can you see that? Or is this blocking it? Okay, great. I can't see it very well. So we do have common problems with toenails. In fact, if you look at your nails too closely, you're almost guaranteed to see something that could be either something you don't recognize, you wonder if it's an injury, you wonder if it's going to create a problem for you, things like that. I will say, and I don't know if I have a picture of it here, there's only one dangerous thing that we see on the feet. And by that, what I mean is one thing that could actually cause you very, very serious long-term health problems. And that would be when you see a melanoma. The only cancer I've ever seen on a foot is a melanoma. And a melanoma would be a very dark black mole. And sometimes they're located under the toenail. Most of the time, I hate to even say that, because like 99.99% of the time, when you see black areas or patches under the toenail, it is a bleeding site where you've actually injured the nail and had a little bleeding under the toenail. But I think if you don't know what it is, if it's there for a long time and you see a black patch under your toenail, you're going to want to have that checked by either your family practitioner. You can come into the clinic here, we can check it out. So black areas under the toenail, or in general, large moles that seem to be growing or causing you problems, by all means, should be checked out. A lot of the times people ask me why their nails are curly. Now, this is something that's so common, I should probably address it. When you're a little kid, your nails are flat and wide. They look pretty darn straight. And then over time, it seems like it's very common for toenails to become progressively more curved in shape. That's especially true for the second toenail. The second toenail can become very curved in shape. And when that happens, people often wonder, well, what's causing that? You'll see at this little X-ray here on the left that there are occasionally bone spurs that grow under the tip of the toe that can push the toenail into a really curvy shape. So sometimes it's the shape of the bone under the nail that causes the nail to curve. A lot of the time, though, that's just not the case. There are changes to the bone and the matrix of the nail at the base of the nail here. So where the nail grows from, actually, the nail doesn't grow quite as rapidly as it used to. The shape of the matrix or the growth center of the nail can change over time. And so a little curvature at the base of the nail, just a little bit of extra curvature as the nail grows out, will cause the nail to fold up. When the nail gets very folded up and it's very contracted and it's pinching together, we actually call it a pincher nail. Even those aren't dangerous, but I will say they're very difficult to trim and take care of. So that's curvature of the nails. Curvature of the nails is what we would call ubiquitous, meaning it's very, very common. So common that we consider it spread throughout the population at a very high level. Not everybody's nails curve over time, but if you notice your nails curving over time, it's very common. If the nail curves enough that the corners are growing in, you probably ought to come in and take a look at it. If it's becoming uncomfortable, difficult to trim, then we might want to see if there's an underlying cause that we could share with you and maybe even treat. So any questions about that? Again, just let me know. Talking again about something that is extremely common. This is one of those problems that I would say is, again, so common that it becomes a majority of the population after age 70. So 3 to 12% of all the population, depending on the study you see, from children up, may be affected by toenail fungus. But those numbers get much, much more common after you get 60s. I think I saw that it was 30%. Over the age of 70, it is 50% and above. So most people, I would say, if you live long enough, are going to suffer a little bit from toenail fungus. It doesn't have to be a medical problem, but what it is, it's an invasion of 3 separate types of fungus, the most common 3 separate types of fungus that can get into your toenail. When they get into your toenail, they start to change the way the nail looks. They alter the morphology of the nail. They change the color of the nail. The nail becomes thick. It becomes spongy, crumbly, powdery. Again, it can become difficult to trim. It can even pull away or loosen from the nail bed. So this toenail fungus is so common that when I see people for other problems, I would say this is by far the most common thing they bring up. So people come in for a broken this or a sprained that, and they'll very often at the end of the visit say, hey, by the way, can you look at this toenail? And we look at it, and sure enough, it looks like they have toenail fungus. Now, you can have other things besides toenail fungus that kind of look like this. One of those would be psoriasis of the toenails. But by far, this is the most common thing. So just so you know, there are some risk factors for it. You know, if you've had injury to the nail, lost your toenails in ski boots, things like that. If you've been on high doses of antibiotics that kill the normal bacteria on your skin, then fungus can overgrow. So you can get some toenail infections. Diabetes makes it more likely. Smoking or poor circulation makes it more likely. But it also does tend to run in families. Where do you get toenail fungus from? That's a big question I get. You get it from basically athlete's foot is the most common way that you get toenail fungus. So you go to the shower, you're traveling, you go to a hotel room, you don't know how well they clean the shower, you stand in the shower, maybe somebody had athlete's foot before you, and you could contract athlete's foot. Athlete's foot that gets under the nail is the most common way for people to get toenail fungus. Other places would include nail salons where you don't know about the quality of the instrument sterilization. And then once you have toenail fungus, you can actually self-spread it. So if you have a toenail that looks like this, that looks abnormal, and you clip that nail and then you use that same clipper on a healthy looking nail, you're just kind of spreading it. You're self-seeding that fungus to your other toenails. So probably a good idea to either have a separate set of clippers for the nails that look fungal, or you can just trim the fungal looking nails last and then sterilize the instrument in between. And, you know, bleach will sterilize an instrument. Most forms of alcohol and Hibiclens and so forth can sterilize the instrument afterward. So that's toenail fungus. You can treat it, especially if it becomes symptomatic, if it's difficult to trim, if it's hurting you, pressure on the toe is increasing, if it's snagging in your socks, you can treat it. You see some of the treatments there. The pills are by far the most effective, but even the pills are not incredibly effective. They're not perfect by any means. This Lamisil is considered the gold standard of treatment that you see right here. Lamisil, 1 pill a day for 90 days. You have to check your liver to make sure you have a healthy liver before you take it. And it is still less than 50% in the study I quoted here. I just saw another study saying it was 56%. But that's by no means 100%. This is not an easy thing to eradicate. And then the other oral treatments are less effective even. People ask me about the new topical medications. Really not very effective.
Dr. Armstrong, we do have one raised hand from a participant. I will allow them to talk so they can ask a question.
Thank you.
Hi, I was wondering if you could tell me how long fungus survives on surfaces like showers.
You know, that's a very good question. It can survive well on dry surfaces. So, you know, it can survive in damp surfaces and damp environments much better than it can on dry surfaces. On damp surfaces, I don't think there's necessarily a limit. On dry surfaces, I've seen anything from 24 to 48 hours. So the fungal spores, though, I think theoretically in a toenail, for example, is very dry surface. So if there are toenail or skin sheddings in that shower, then really I think that could go on quite a bit longer. It could go on for several weeks probably. So that would be on the macro scale, because it does survive in your toenails without a lot of water behind it. So in theory, even if a surface is dry, if there are shed skin flakes or shed toenail fragments, I don't want to put, terrible images into your mind, but that could spread for longer.
So what do you recommend to clean after somebody that you think it probably has toe fungus?
Chlorine-based cleaners are the most effective. So if you use the Clorox wipes, you can certainly get an effective cleaner with other substances too. Some of the quaternary ammonium cleaners, I think what is that one we use all the time? Cavi wipes, but that's kind of medical. Any of the various substances that you use to clean in the little wipes could be effective, but in general, I think the most effective is a cleaner with a chlorine base. When you're traveling, I think it's a good idea to either wear flip-flops or put a towel down in the shower. When you go to a gym repeatedly, many times, you probably just want to wear flip-flops, or if you go to a pool surface, I think you could assume that you're going to be exposed to fungus. Now, the good news is this: it is contagious, but it's mildly contagious. If it were really aggressively contagious, all of us would just be covered in fungus all the time, because we do get a lot of exposure to it. When your skin is healthy, your skin is intact, you're usually going to be protected. But if you want to minimize your risk, then you certainly would want to wear, flip-flops or put a towel down.
Okay, thank you so much.
Thank you.
Thank you. And remember, if you unmuted yourself to ask a question, go ahead and mute yourself after the question to avoid any unnecessary sound.
Sure. Yes. Does it matter if you just leave it alone? What's
No.
the downside?
I would say most
next question.
most of the patients we see it in do just end up leaving it alone. And basically it's cosmetic care. You just trim it. One thing that you can do is, because the nails become so thick, that's where most of the symptoms come from. So what we usually recommend is you just file the nails thin. So in other words, don't just file them short, don't just trim them short, but file the top of the nail so it's not so thick. And then you usually have no symptoms whatsoever. It just becomes a cosmetic issue. It's rare that it becomes painful and symptomatic, I think, but it can, so. All right, any other questions? We'll move on. This is one of those slides I was warning you about. I don't know how many of you have suffered with corns or calluses. So a corn and a callus are the same thing, the same material. They're made of the same stuff, and that stuff is keratin. But they're different in one sense. That is, calluses are flat. They sit on the surface of the skin. They protect you and help you, if you've got a lot of shearing forces or pressure. When that callus dives down, kind of pokes into your skin and goes deep and becomes painful, then we'd say that that is a corn. And that is named, just after, you could probably tell, just after the way a kernel of corn goes down into the cob. It has kind of that triangular shape, works its way down in. And that is, these are some of the most painful things I see. I mean, people will come in with bunions and hammer toes and all kinds of problems, and the only thing that will really hurt them is some deep corn that they have, either on the top of their pinky toe, between their fourth and fifth toes, or the bottom of their foot. The foot that you see on the left would be a very painful foot indeed. There are people who are more prone to corns than others, families who are more prone to corns and calluses than others. Certainly smoking and diabetes are risk factors for corns and calluses. That seems a little counterintuitive, but if the circulation to your skin is compromised in any way, and so such as when you smoke and there's this constriction of your blood vessels, so there's less circulation going to your extremities, then that does lead to more easily injured skin. If your skin is more easily injured, then your body's response to prevent that injury is to build up thick material around the bottom of the foot and the toes and so forth. This corn that you see here is almost always a tight shoe problem. You don't get this corn walking around barefoot. You have to have a shoe rubbing on that toe to get that corn. These other corns, though, this is somebody who has quite a tendency toward corn formation. There is there's a problem which actually has a name. It's hereditary multiple keratomas, but you know, most people don't have that. Most of the corns we see are mechanical, meaning they're from walking, getting friction, twisting, shearing forces on the bottom of the foot. You're certainly able to just kind of shave or buff these away if you have them. But once they go as deep as they are on that left picture, I think it becomes a much more difficult issue. And this is kind of this is a tough area for people because they can have a corn that is so painful, it can be really decreasing their quality of life. It can be preventing them from doing things they want to do, cause them quite a bit of pain. And yet there's no coverage through medical insurance to have these corns treated. This is something we run into from time to time. Well, we run into almost all the time because clearly that becomes a painful medical problem. And yet I think Medicare considers it and many other insurances just consider it like getting a haircut. You know, it's like, well, we're not going to cover that. That's just a routine maintenance thing. So it's something that we struggle with. I will say this, if you have that look of the left foot and you don't know about your insurance coverage or you don't know what you can do about it, certainly there would be some things that you'd want to do to try to address it. And I think there are ways that we could help. So don't suffer if you have a severely painful corn. You know, we'll talk to you about what we can do. We can even get some medications or different things to try to work on it. And occasionally we can even help with debridements and so forth. Is that your understanding? Yeah. So just realize this is a tough area. It's a tough area to get insurance coverage for routine treatment for corns. So if you come in to talk about a painful problem you have with corns, that is 100% covered. What's not covered is people who come in and say, can you shave my corns every 6 or 8 weeks? That's where it becomes kind of an out-of-pocket expense. And we're happy to do it. I just don't want people to get surprised, you know, by when the insurance doesn't pick that up. So these calluses, to some extent, you can prevent them with, or keep them softer and less painful with what are called keratolytics. So there are lotions, there are creams that have either salicylic acid, ammonium lactate, or urea. And those creams, if you use them regularly, will soften the corn and callus formation. They also help dissolve some of the cells that are forming and becoming larger. I don't think it's strong enough to deal with something serious like you see here. But I think for most of us, it can be very helpful in preventing the formation, at least as rapidly. They don't form as rapidly when you have those. And if you don't have diabetes, you know, you're perfectly entitled to treat your own corns. If you have good circulation, no diabetes, then you can use different plasters, corn cream, callus cream, things like that on your feet. If you have diabetes, we strongly discourage you from using any type of strong acid or corn plaster, callus pads on your feet, just because it could open up a wound could become infected, and we'll talk about that. So any questions about corns, let me know. Heel pain. This one is so common that I'm happy to talk about it. If there's anybody who has heel pain, we certainly could. I wonder if I should skip that. Yeah, that's Achilles tendonitis. Why don't we talk about heel pain, just because it is by far the most common reason people come into a foot clinic, aside from, you know, just routine things. This is the most common structural problem that people come into any foot clinic for. And it's that pain in the heel, and everybody's probably heard of it. It's plantar fasciitis. You get out of bed in the morning, it's a sharp pain under your heel. It takes you a while to warm up. You warm up, get it moving, and suddenly it feels a little bit better. You can actually get through your day, but by the end of the day, once again, it's very painful. It doesn't seem to come from any injury. People say, I've been doing the same thing for 20 years. Why does my foot hurt now? And I never know why. I don't know what triggers this or gets it started. A lot of the time, it's no injury, it's no change of shoes, no change of activities. It just happens. And what happens is you see this tissue that kind of holds up the arch of the foot. That's called the plantar fascia, really powerful belt of fibrous tissue that holds the arch of your foot up. Right here is where it's the most vulnerable to injury. So right there at the heel, right where you see it showing on this image, is where that foot is under, that fascia is under tremendous stress. There's stress from the Achilles yanking from the back, from pressure on your heel as you walk. Sometimes people fall and land on their heel and it's very painful. So that is the way that plantar fasciitis might sometimes get started. But what it is essentially is these little tiny microscopic fibers will sustain microscopic tears. So it's not like you rupture it, you just, some of the fibers begin to break down. And as they do that, first of all, that's painful. But second of all the muscles in the foot right at that spot start to knot up and tighten, trying to protect you. So, you know, that's why it's so painful first thing in the morning. There's a significant amount of like contracting muscles around there, tightening up, not wanting you to step on it or use it. They try to splint it. So micro tears in your plantar fascia are what lead to the chronic week in and week out plantar fasciitis. I don't really want to go into that slide too much. But basically, this is a problem because the tissue is poorly circulated. It's easy to injure because it's under so much stress. And then when it does get a minor injury, it doesn't seem to heal. So before your body can kind of repair the damage, you've walked on it again. And then before that damage can repair, you walk on it again. So it stays kind of chronically in a state of injury, partial healing, not able to heal. And so there are ways that you can try to get it to heal, ways you can increase the circulation. You can result in tissue that's under less traction, less force. And the most important way to prevent and treat fasciitis seems to be stretching. Stretching your calf muscles specifically. So if you start to even feel a little twinge in your heel, and I've been there myself, you feel a little twinge in your heel, you don't want to get the dreaded plantar fasciitis. You just begin stretching your calves. You stretch them regularly, 3, 5, 10 times a day. You really can't overdo it if you're doing it carefully and gently. So you stretch your calf muscles quite a bit. It seems like it seems like you're not directly treating the problem by stretching your calf muscles. But again, the studies have been pretty definitive, I think. They do demonstrate that's the best way to prevent the fascia from continuing to hurt and preventing problems in the future. So stretch your calves, stretch your hamstrings, stretch everything, frankly, but this in particular is a calf stretch. So that's plantar fasciitis, a very common problem. When people come in here, sometimes we give them a cortisone shot, sometimes we send them to physical therapy, get them orthotics, wrap the foot, tape the foot, different things that we can add to that stretching regimen. You can also buy a thing called a fascia night splint. So it's a splint that you wear at night for your fascia. So if you look up night splint plantar fascia online, you can buy them from Amazon or any number of places. They might even sell them over here at Walgreens. They're not that uncommon because this is a very common problem. It can be very painful and limiting. Fortunately, it's not dangerous in any way. It typically is not associated with any bone breaks or anything like that. But it feels like it is. So Achilles tendon problems also very common. Can you see the tendon on this right slide? Okay, so this isn't there on anything but mine. Okay, I'm just going to minimize it here. So here you see the, if you have swelling and enlargement, this is a little different than the fasciitis. And the reason it's different is because fasciitis is not, when you have plantar fasciitis, the worst thing that could happen is you could tear the fascia a little bit, it'll heal and you'll be fine. With this problem, when you see actual swelling in your Achilles tendon and enlargement, thickening of the tendon associated with pain, that can be much more worrisome because the last thing you want to do is have a tear of your Achilles tendon. You see an MRI image here on the right side. This little area right here is called heel bursitis. So there is also bursitis in the shoulder, bursitis in the elbow, but you can have bursitis in your Achilles. It's very painful. The good news is when you have bursitis of your heel, your tendon is not in imminent danger in most cases. The bursitis can be treated. Your tendon can be, can avoid injury. But when you see this thickening higher up in the substance of the tendon itself, that's a little worrisome. That should be checked out and it should be treated because, like I say, when that ruptures, that's catastrophic. When your fascia ruptures, it certainly isn't. Sometimes you can see spurs in the heel. You see a little tearing in the tendon. So this is just an MRI of an Achilles tendinosis. This is a common one we get. Obviously, people worry about bunions. A bunion this size believe it or not, might or might not be symptomatic. I can't tell you, I'd say most of the bunions I see are not very painful. You know, people come in because it's obviously concerning to have your foot aligned like that, to have a bump sticking out that far, have your big toe either over or underlapping the second toe. But the pain usually comes from other problems. So the pain can come because this bunion isn't taking a share of the weight. So all of a sudden this toe is getting painful from walking too much. We call that metatarsalgia. Pain can come because you could form a corn between these two toes. That corn can be much more painful than the joint being crooked like this. Another common complaint, though, is I can't fit into any shoes. And you can see how it could be difficult to fit into a shoe like that. One common question I field in the office that I don't know if you have questions about or not, but people often wonder what a good wide shoe is. And there are some wide shoes out there. If you have the ability to get over to Independence Run and Hike in Carbondale, they have shoe fitters who can get you some wide shoes. I am sure Treads in town in Glenwood can get wide shoes for you. Maybe not as many running shoes, but certainly hiking and climbing and various casual boots and so forth. You can look online for wide shoes, but I'll tell you, it's tough to get shoes online unless you're able to try them on. It's much better to be able to go into a place, try them on. The nice thing about full service shoe stores like the ones around here would be that if you do try it for a few days and it's just killing your foot, you could take it back. Skechers make some wide shoes. They're called D-Lights. Keen, K-E-E-N, makes some very wide shoes. And so beyond that, you know, certainly this is a problem for people who have a bunion like that. I don't know who makes a shoe specifically wide enough for a bunion like that, because part of the problem is you get a shoe that's wide enough in your forefoot and the heel is too narrow. So your heel slips out of the back of the shoe when you finally get one that's the right size for the ball of your foot. So there are ways we can deal with that. If you have a bunion like this, if you're having problems with it, if it's painful or if it's just a pain, we have a really good resource here at the clinic. Russell Bolig is an orthotics guy, but he also knows a lot about shoes. He's fit people for shoes for many years and is very talented at it, so he can give us some insight. You can stretch the shoe and so forth. So certainly happy to help with anything like that. Bunions are very interesting, though. The reason I bring this slide up is just because I'm fascinated by this archaeology. When this pointy-toed shoe became popular in the Middle Ages, you go from skeletons in graveyards having no bunions. So the 14th, 15th centuries, okay? So the 1300s and 1400s, shoe gear was wide, it was kind of square, it was kind of frumpy looking, but nobody had bunions. Then all of a sudden you start seeing these shoes becoming fashionable, these poulain shoes, these pointy shoes. And all of a sudden, there are many, many bunions in the graveyards in Europe. So we know bunions do come, partly at least, from shoe gear. I think there was a study that was done about shoe populations that never wear shoes. And the incidence of bunions there was something like 1/20th of what it is in populations that do wear shoes. What we think causes a bunion, and also women get bunions much more than men. And we think that is also attributable to their shoes because men and women have the same feet. You could never tell just looking at a skeleton whether it was a man or a woman. I mean, you could say, well, men sometimes have bigger feet or whatever. But women have a higher incidence of bunions, and we think it's because your shoes. So definitely you don't want to wear shoes that cause a lot of pressure at the ball of the foot. Even regular shoes, though, can put your foot into a position where bunions are more common. What we think, you know, the most common explanation now for what causes bunions is you inherit a predisposition towards your foot kind of spreading out over time, which just has to do with the stability or looseness of your ligaments in your foot and so forth. So if you inherit a foot that tends to splay and spread out, then you put that foot into shoes of a certain kind, that's how you're going to get bunions. So it's interesting, there were enough problems with these poulain shoes that in 1463, King Edward IV outlawed toes that go anywhere past 2 inches beyond. The shoe cannot be 2 inches beyond your great toe. So there you go, some legislation in the interest of the people. Any questions about bunions? This is a little bit more just to show you what the x-ray shows, and I think you kind of saw that. So here is where we think the foot spreads out. This should be nice and parallel. You'll see this bone is leaning out away from this one. So as your foot spreads out, your big toe can't stick way out to the side. The shoes push it back in. People who live in Samoa and Fiji who don't have shoes pushing their big toe in, they'll have a foot that's splayed. The bunion can almost look like a thumb, the bunion area, but it doesn't have the bunion bump because nothing has pushed their big toe crooked. So definitely it has a lot to do with the shoe gear, I guess, is the take-home message on that. So let's go to the next topic. This is just showing how we correct bunions. So these are the toe deformities that we talk about. Everything we see that looks like a crooked toe, we tend to call a hammer toe. But there are different types of hammer toe, and we actually call them different things depending on what they look like. If you have a painful spot at the tip of your toe here, and you're walking around on a toe that looks contracted, that's not a hammer toe. That's actually called a claw toe. It's because the tendons are too tight under your toe. So if your tendons are too tight, you're going to walk on the tip of your toe. You're going to get a blister, corn, or callus, or even a wound that can be very, very painful. It can even get infected, so it could become a health issue. A hammer toe, a classic hammer toe, is bent at this joint, but then kind of straight at the joint past it. So that's what a hammer toe would look like. You rub at the knuckle here, or you get pain under the ball of the foot here. So under here. The mallet toe is a toe that's really long, and so then it just gets bent at the very tip by shoe pressure. So we have different reasons that people get hammer toes. If you have a hammer toe, or quote unquote a deformed toe, because of the types of shoe you're wearing and your second toe is getting bent down, that's probably a mallet toe. Most of what we see though are hammer toes. Hammer toes come from this joint drifting up and out of place a little bit and the toe bending in the middle. So these are really common problems. They actually tend to be more painful than bunions a lot of the time, especially when they're first developing. The pain will be usually on the ball of the foot by the second toe base. So under the second toe base, that pain, a lot of people come in saying, I think I have a neuroma or this or that. And actually it just turns out their joint is very sore because they're starting to develop a hammer toe. So how are we doing on time? Good. Where are we? I want to pause for a second, see if anybody has any questions. I just keep rambling on. So please let me know if there's anything that we have not addressed or any specific questions. You can even say that it's your cousin or a friend that you're asking for. You don't have to out yourself. We'll be happy to talk about it. So now let's move on then. Talking about these joints that are painful, these hammer toes. You'll see on this x-ray on the right, there's a bad bunion, and then there's a hammer toe that's so severe the toe is actually dislocated. This toe is sitting up above where it's supposed to sit. So this is supposed to sit right there. Instead of sitting like this, the toe is sitting like that. So the toe has become dislocated. And that has to do with the fact that you've got a bunion here that is not taking its share of the weight, transferring too much pressure to this joint. This joint is a smaller, weaker joint. So it can easily become overloaded by the stresses of weight bearing. And in response, this toe will dislocate. It will move up and off of its joint. That's part of what can happen in a severe hammer toe. You can actually
Dr. Armstrong, we do have a question.
Okay.
And this is from Kimberly. Okay. You are, see if you can unmute yourself, Kimberly. Okay, you can continue. Kimberly, as soon as you are able to unmute, you can ask your question.
Oh, gout. Okay. We have a, was it a written question?
Yeah, it's in the Q&A.
We have a Q&A.
It was an error with the raised hand. We can continue.
Yeah, but there's in the Q&A.
In the Q&A, there's actually a question about gout, so I want to address that.
Good.
I don't have slides on gout, but we do see gout quite a bit. So gout would be a hot, red, swollen joint, usually the big toe joint. it's extremely painful. In most cases, an acute attack of gout is very, very painful. One of the more painful conditions that we as humans are exposed to. What happens with that when you eat foods that have a chemical called purines in them? Those purines are broken down by your metabolism into uric acid. Uric acid, we all have it in our bloodstream. All of us have more or less uric acid in our bloodstream. Some people, though, whether they have kidney problems, whether they have, they're on a medication that causes them to hold more uric acid in their bloodstream, whatever reason, if they inherited a high level of uric acid, it can actually be passed through families. Then the uric acid level gets so high that this dissolved chemical in your blood will precipitate. It will form crystals around a joint. And the joint that it forms around is always the big, not always, but very commonly the big toe joint. The reason for that is it's easier to make crystals, when the temperature is a little cooler. So I tell people it's kind of like when you're dissolving sugar and you want to dissolve all the sugar when you're making rock candy, you have the temperature pretty high so that you can dissolve the sugar. Then when you cool it, it crystallizes. And it's the same thing with this uric acid. You can have a high concentration dissolved in your bloodstream and it gets around a cool joint like this big toe joint, and it will actually turn into crystals. And those crystals are extremely irritating to your body. They're like little shards of fiberglass being deposited all around your big toe joint. So it's very painful. Typically, it has a little bit of what we call a prodrome. So you'll feel a little hint that it's coming on, whether it's numbness, a mild burning, tingling, something like that. Sometimes people who are used to having gout attacks know when one is coming the night before it ever happens. And then they wake up the next day and their foot is really painful. So there are diets that you can look up. And I wanted to just show you the one that I like the best is called Elevate Health Arizona purine content. Remember, purines are the chemicals you want to avoid in your foods. So I don't know if this will work, but we're going to try it here. Oh, can you type it in, Cindy? But look how well I wrote that. Cindy will get that into the notes here, because that's a really helpful site. You can actually look up how much purine you're eating when you eat different foods. If you think you might have gout, two things I would tell you. One is hydrate really well, okay? If you get dehydrated, then of course you're going to have a higher concentration in your blood of uric acid because your blood is just more concentrated. So stay hydrated. The other thing is check the purine content of various foods. And try to avoid foods that are very high in purines. It's not always the one people think, it's not always those foods like red meat and, wine and so forth. Sometimes turkey, salmon, trout, chicken even. So some of these foods that you wouldn't expect to have a high content of purines can have a high enough content to kind of tip you over the edge. If you do have gout, if you have an attack, if you suspect it's gout, it probably is, because there's only two things that cause a really bright red, extremely painful foot in most people, and that would be either infection or gout. You would probably know before you got an infection because you would have a puncture wound somewhere or an ingrown toenail or a blister that became infected. So it's rare to just wake up one morning with a massively infected big toe joint, but it's not rare to wake up with a massively gouty big toe joint. In that case, what we do is we ask people to come in. They usually require medicine to treat the attack and then pain medication. Because like I said, it is very painful. It's difficult to sleep. It's difficult to put a shoe on. You can't go to work. Can't even stand to have the sheets touching your foot. We do have medications to lower the level of uric acid in your blood. So if you have multiple gout attacks, you might want to get on a medication called allopurinol or a different one called Uloric, one of those two, to prevent you from having repeated gout attacks. If you're taking a diuretic, a water pill called hydrochlorothiazide, you would want to get off of that pill if you're having gout attacks, because that causes you to really raise your uric acid levels in your bloodstream. So I hope that answers those questions. If not, write back again if there's something specific we haven't covered. Anything else before we go on? Okay, so this is the dreaded Morton's neuroma. I don't know why, whenever I say Morton's neuroma, I say the dreaded Morton's neuroma. It's like a little verbal tick I have, I guess. It is unfortunately a very common problem. It can be very painful though. It's not dangerous in any way. It is just a nerve that has grown extra large based on repetitive trauma. So you'll see that that's typically shown between the third and fourth toes. That is where the vast majority of neuromas are. And there's reasons for that. That's where two big nerves come together. It's where the two sides of the foot interact with each other. So that's an area of high stress and also a fairly nervy area. So you can get a lump of tissue growing around the nerve. On this image, you see the nerve is normally about as big around as, you know, the lead of a pencil, for example. But when you get a neuroma, that becomes much, much larger. It can be as large as a bean. Usually they use beans to describe it. So we have the kidney bean, which is a very large neuroma, the pinto bean, a little bit smaller, the fava bean or something huge. And they often do need to be removed, but very often you can also treat them just by wearing shoes that are wide enough. Excuse me. If you have a shoe that pushes side to side and squeezes your foot, you can see how that would pinch the nerve from side to side. The nerve has nowhere to go. It's stuck between those two bones called metatarsals. So if you have tight shoes, if you're wearing high heels, if you have really tight calves and you don't stretch, there's the stretching again. If you have that, then you can easily irritate the nerve, make it grow, and you can get a neuroma. Neuromas can be very painful also. Sometimes they just feel like there's a sock wadded up under the ball of your foot. That's a very common thing I get. Sometimes people feel like they left something in their shoe. They take a look at it, there's nothing there. You hike for a mile, your foot becomes all of a sudden more and more painful until you have to stop, take off your shoe, rub the area, and then you feel better. So that's the Morton's neuroma. Again, not dangerous. It can be very painful. And one more thing, it does tend to shoot symptoms toward the toes. So these little nerves that you see here, even if you're irritating the neuroma, sometimes you feel it at the tip of your third or fourth toe. And again, we have special accommodations we can put in your shoes, give them a cortisone shot to actually shrink them. This is one area where cortisone is not just masking your symptoms, it's actually helping shrink the neuroma. So it's not a bad idea to get a cortisone shot for that. Try to shrink that swollen nerve before it gets so big that you can't deal with it. You have to take it out. So that's Morton's neuroma, named after Dr. Morton, not the salt guy. Where are we with that? What's that? Okay. Are there any questions? Please feel free to chime in if there are, because we have just a few minutes left and I do want to talk about diabetes. I don't know how many diabetics there are in the audience. There are things that we worry about with diabetes. As you look at every package, when you buy any foot supply, it says, ask your doctor if you're diabetic before you use this, or just plain don't use this if you're diabetic. This is something that I actually saw. I had a diabetic patient, it wasn't this exact one, but I found an image that looks just like it. I had a patient who drew a bath, so poured bath water, stood in the bath water for a few seconds, getting, a few things together, and then sat down in the bath and immediately realized that the water was scalding hot because he burned his bum when he sat down in the water. Mm-hmm. In the meantime, he'd had his feet sitting in that water for a few minutes being scalded. He came out with second-degree burns over about 75% of his feet, we figured out. And it was all because he couldn't feel the water. He didn't check the water with his elbow, which is what we usually tell people to do. Check it with your elbow before you stand in it. If you have diabetes, you have to get into some habits to prevent things like this. I have another patient who fell asleep next to a space heater and woke up with severe burns across multiple toes because he couldn't feel the space heater on his foot. Diabetes is dangerous for feet precisely because sometimes the nerves don't work very well and you can't feel things. This is a brown recluse spider bite. I don't think we have those here, at least not in this part of Colorado, I hope. But a bite from a brown recluse will look like this, the day after, and then a week or two after it will look like this. So it's tissue toxic. It causes the tissue to just kind of die off around the site. So the moral of this is if you have diabetes, you want to check your shoes before you put them on. The patient that I saw with this was not this exact patient, but the patient that I saw with it had just put on a shoe, sustained a spider bite, found the dead spider, but actually by then had been bitten and then had a long healing process. I think we ended up sending him for a skin graft. I'm not sure what happened after that, but long healing process.
Okay, that is
Let's
right.
field those questions.
We have a couple of questions. Ron, you can go ahead and ask, followed by Zoom. Would you like me to relay the question?
I got it. I've got it. Thanks. Yeah, I had an experience where I had some, significant but not serious foot pain on a vacation. I ignored it. I got home. It's a little better. I ignored it some more. It got worse. By the time I got to a doctor 3 months later, I'm now walking around with a blood clot in the top part of my leg and on Eliquis for the rest of my life. So I was wondering, if you could say something about foot pain as an indicator of other conditions.
So, specific to that, I don't know if you noticed quite a bit of swelling on the side with the blood clot, but yeah, one of the symptoms of a leg clot and what we call coach class syndrome, where people sit for a long period of time in planes or cars or whatever, so they develop blood clots, would be what we call unilateral swelling. So swelling and discoloration of the foot are very, very common in blood clots. And so if you do develop swelling on one side over another, or if both, I guess you could get a clot in both legs. There's no reason you couldn't, but it's just not as common. So if you get discoloration, kind of a dull, aching pain in your feet, and so forth, then it certainly is a worry. We do see a fair number of blood clots in the leg here. And sometimes people come in because their feet are hurting. So that's one possible manifestation. And certainly we encourage people, whenever you fly, or even if you drive a long period of time, get yourself some compression hose, or even the copper fit socks at Walmart, or a nice compression. Get yourself something compressive so you don't end up with this high risk for blood clots. Stand up and move around when you can. There are other things that are foot pain that's a systemic problem. The most common there would be like a back injury or a nerve entrapment higher up in the leg that can present as pain in the foot. In fact, I would say a lot, but every now and then we see patients who come in and they have a lot of foot pain, and we say, you know what, I've looked around everywhere. I've taken x-rays. I don't think your pain is coming from your foot. I think you're feeling pain from a sciatic or other nerve entrapment, and you're feeling that in the foot. So that's certainly a problem that you could see also. That's not, there's not too many things that systemically are going to cause your feet to hurt that I can think of. Certainly there are arthritides and autoimmune problems that present as swelling, redness, and sometimes severe pain in the foot, something we call erythromelalgia. It's really, it's not an easy word, but it's something that we do see. You can see changes in your foot from things like psoriasis. Psoriasis has an arthritis that often affects toe. You can hit a horribly swollen toe from different types of what we call seronegative arthritises. So arthritises that are not rheumatoid arthritis, not just the common osteoarthritis, but a different type of arthritis. So yeah, things can manifest in your feet. I think that's a good point. Well made.
My question in the chat.
Okay.
And he wants to know suggestions for management of Raynaud's disease when you need to be outdoors in the winter.
Oh, great question. That's very common. Around October, we get our influx of people with blisters on their toes. So what happens with Raynaud's? Raynaud's is a problem where either you can have it because you have arthritis or an autoimmune condition, or you might just have it because you have reactive blood vessels. So what Raynaud's is when you get exposed to cold, caffeine, nicotine, emotional stress, all these things can be what we call triggers for Raynaud's. And what happens when Raynaud's gets triggered is the very, very smallest blood vessels right before the capillaries constrict, they shut down. And so your fingers and toes become starved for oxygen. So they turn white, for example. I have a son who, if he gets in the ocean in California, he takes his hand out, it looks like he's wearing white gloves because his arteries constrict so badly. But a lot of people around here, how it manifests is they'll go out skiing, their feet will feel very cold, but then when they look at them, they see they have blisters on their toes or damaged skin, even gangrene. there's two different types of Raynaud's that we classify. One is with gangrene, one is without gangrene. So it can actually cause you to, patches of skin to die off. So you expose yourself to cold, the artery slams shut, your toes are starved for oxygen. The skin actually without oxygen can die off in patches and become badly injured. And then that's very painful sometimes. The way that we treat it is, first of all, keep your feet very warm, avoid triggers or things that could be adding to it like nicotine or caffeine. The other way, though, is we use medication. There are medications that will not allow your little vessels to constrict when they experience cold. So your feet stay nice and warm all day. One of those is Procardia. You take a Procardia when you go out skiing, you're going to have warm fingers and toes. You're not going to have a Raynaud's attack in most cases. The biggest side effect from those is they may lower your blood pressure a little bit. So if you get a headache, a lot of people are surprised that Viagra is a very good drug to prevent Raynaud's, because it does not allow those arteries to constrict. You can't have those, your skin does not become starved for oxygen. Raynaud's is almost, I almost think of it as kind of a healthy person's problem. It's much more common in females with low blood pressure than it is in hypertensive males. And it's because the blood pressure is low. When the arteries constrict, it's that much easier for them to shut off the blood flow. You don't have this high blood pressure forcing the blood through to your skin. Whereas sometimes people with high blood pressure seem to be almost immune from Raynaud's because the pressure in their circulatory system just pushes the circulation to their skin. So I don't think of Raynaud's as a serious medical problem, but it sure can be very painful. It has an excellent treatment. There are several excellent treatments, so I don't think you have to move to Arizona if you have Raynaud's, which I have had patients threaten to do until they had proper treatment. The treatment is keep your feet warm, and then there are oral medications that will last 12 hours and keep your toes and fingers warm when you're out skiing and so forth. So hope that helps. Anything else? Okay. Well, I mean, here's this about diabetes. The problem with diabetes is basically you have poor circulation, the nerves can be damaged, and in a blood sugar level over 300, your immune system is just basically shut down. Your white cells do not migrate to help you fight an infection. So not only can you get injured because you can't feel things because of the neuropathy, when you do get injured, you can't supply enough blood to heal that injury, and your immune system doesn't respond to invaders quite as quickly as it needs to. So that's the triad of the diabetic foot type. That's why diabetes can be so dangerous for people's feet. That's why it's very important to get into good habits if you do have diabetes. Check your feet every day. Look between your toes. Look on the bottom of your foot. If you see blisters, if you see wounds, if you see bleeding, if you see a puncture spot, you're going to find it within a day. It's not going to have a chance to get infected. All of the big problems I see from diabetes, the amputations, the lost digits, the lost, whatever it is, large ulcers that don't heal, typically come because people hadn't really known it was there until sometime later in the game when it become a bigger and bigger problem. So that's diabetes. This is very rare, so I don't think we need to talk about that. If you have diabetes long enough, if you have a bad enough case of neuropathy, your joints and bones can actually kind of collapse. So.
Another question.
Yeah.
Can you take the medication for Raynaud's only when you are going to be in the cold for long periods of time, or do you need to take it daily?
So that's a good question too. The good thing about this medicine is it is not something you have to be on every day. It's not like you're quote unquote on a pill. It is something that you take if you need to be out in a cold day. And so what most people would do is on ski days, they would take it. But there are people whose Raynaud's is severe enough that they have to take it every day through the winter. But even then, if they're going to be indoors for the day, if they're, there's no need to take it. You take it as a way that when you're going to be cold exposed, you're protecting yourself. So it's just like putting on your gloves, putting on your warm boots, take your Procardia, go out into the cold. If you're not doing all that, you don't have to take Procardia or amlodipine or anything else. It's just an as needed medicine. So a lot of people are hesitant to get on another medication. I understand that. And you're not really on another medication when you get on these medications for Raynaud's. You're just using them when you need to. So. Looks like there's another Q&A there.
And she's asking if we can type out the medication in the checkbox. Like we just sildenafil and.
Sounds good.
and
Yeah, you could try there's 3 that you could put in: nifedipine, amlodipine, and you could put in Viagra. All right, any other questions? I think that's kind of it for my presentation, so I don't have much more. So if there are any questions, let me know. And if not, thank you very much for coming and listening. I can't see you, but I appreciate you attending.
Thank you so much, Dr. Armstrong. I think we are about done for the day. This was wonderful. I was glad I was muted when the spider bite image came up, but anyway, thank you, everybody. This video is being recorded and will be available in the library's YouTube page. It was live streamed to Facebook, meaning that the recording for this is already available at the Garfield County Library's Facebook page if you need to access it right away. If not, the video will be available first thing tomorrow on our Facebook page. YouTube page. And that's about it. Thank you, everybody, for joining us, and have a great day and stay safe. It's kind of snowing out there tonight.
Yeah. Hey, thanks for setting this up.
Thank you so much.